Welcome everyone to the deep dive. We're here to plunge into some of the really intricate, often surprising and frankly sometimes just awe-inspiring aspects of our world. And today, we're not just looking at a topic, we're actually stepping into the high-stakes arena of modern medicine, specifically the incredible precision, the ingenuity needed in minimally invasive surgery. You know, when you think about surgery, maybe your mind goes to like wide open incisions, direct contact, a clear view. But for a huge and growing part of what happens today, especially in things like laparoscopy, the surgeon's work is, well, it's largely unseen by the naked eye. Instead, they're relying on these incredibly intricate hands that extend into the body through tiny incisions, often, no wider than your fingertip. Okay, let's unpack this. Just try to imagine, if you will, the sheer mind-boggling challenge of doing really delicate life-saving work like tying sutures, dissecting tissue, taking out organs all through just a few small ports. Yeah. Your own hands are miles away, relatively speaking, manipulating these long, slender instruments while you're watching a magnified, kind of flat two-dimensional image on a screen. It really is like building a tiny ship in a bottle, but with the added pressure that every single movement, every gentle grasp or firm hold carries the weight of, well, human life. So this isn't just about dexterity. It's really about the profound engineering of the tools themselves. These tools become like direct extensions of the surgeon's will and skill.
You've really articulated the high stakes perfectly there. So as we get into this deep dive, let's maybe approach it like a focus session you might actually find at a high-level medical conference. A kind of concentrated exploration designed to distill the essential but really practical knowledge about the foundational instruments of laparoscopic surgery. And specifically today, we're diving into grasping and holding instruments. And let me tell you, these are, without exaggeration, really the unsung heroes of the operating room. They are the primary interface, the sort of digital to analog translators, if you will, that let surgeons navigate and operate inside the human body with incredible control and, crucially, safety. So our mission today, then, is to kind of peel back the layers on these critical instruments. We'll explore their specific designs, their varied and sometimes surprising applications, and, maybe most importantly, the vital safety protocols that underpin their effective and, above all, safe use. What might seem like simple tools at first glance are actually highly specialized extensions of a surgeon's skill. Each one is meticulously crafted. It's not just about picking things up. It's about interacting with the incredibly diverse, incredibly delicate biological landscape of the human body with precision and respect, transforming potentially damaging actions into life-saving maneuvers.
That sets the stage perfectly. So when we talk about the fundamental role of these grasping and holding instruments, we are quite literally talking about the surgeon's extended hands, right? Our source material points out their core function to pick up, hold, and manipulate tissues. Now, for anyone listening, that might sound almost, well, trivially basic, like picking up a pen from your desk. But here's the thing, the profound insight that often goes unappreciated. In laparoscopic surgery, this isn't just basic motor control, it's a fundamental act of translating these like macro movements of the surgeon's hands and wrists outside the body into micro-precision movements of an instrument tip inside the body, all through a pretty complex lever system.
Exactly. And the most significant shift here, the real game changer, is the almost complete removal of direct tactile feedback.
Right, the sense of touch.
Precisely. In traditional open surgery, a surgeon's gloved fingers can feel the texture, the tension, the resilience of tissue. That's vital sensory input. In laparoscopy, that feel of the tissue, which is so critical for safety, is almost entirely mediated, or sometimes even kind of removed, by the instrument itself. So these tools aren't just passive clamps. They're really active partners in the surgical process. They're designed to give the surgeon a sort of proxy for touch, albeit mostly through visual cues on a monitor and maybe subtle resistance felt through the instrument handle.
So think about the sheer dexterity and judgment needed there. It's not simply about holding a piece of tissue still, no. It's about maybe gently repositioning a segment of bowel to get a better view without damaging its really fragile walls. Or it's about applying just the right amount of tension to a structure, maybe a blood vessel or a fascial plane, to help with dissection or to create exposure in a really tight anatomical space, all without tearing or crushing. These actions are absolutely crucial for setting up and maintaining a clear, bloodless surgical field, and for safely performing the next delicate step of the procedure. Without these incredibly precise engineered extensions, a surgeon would be, well, effectively blind and powerless inside the body, unable to interact with the anatomy. This is why it's so important for you, the listener, to understand. Imagine trying to do really intricate work, like maybe untangling fine threads using kitchen chopsticks through a tiny keyhole. These instruments are, of course, far more sophisticated, but that principle of indirect yet exquisitely controlled manipulation is the absolute cornerstone of every successful laparoscopic procedure.
And this inherent challenge, the challenge of indirect manipulation, coupled with just the incredible diversity of human tissues, leads us directly into the overarching classification system for these instruments. Our source says they can be atraumatic, traumatic, or specialized. Yeah. Now, what's fascinating here is that this isn't just some arbitrary categorization. It reflects a deep, almost you could say, biological understanding of the diverse nature and biomechanical properties of tissues within the human body, and the very specific requirements for handling each type. Think about it, the delicate thin wall of an intestine versus, say, the tough fibrous capsule of an organ like the liver, or maybe the smooth slippery surface of a gallstone. Each one presents a unique challenge, right? And each demands a precisely engineered solution. Different jaw designs, different gripping surfaces, different ways of distributing pressure. So this classification system is really a profound testament to the thoughtful engineering, the sophisticated material science, and the collaborative surgical insight that goes into modern surgical tool design.
And from the surgeon's point of view, in the middle of an operation, this system must simplify things enormously.
It does. It simplifies incredibly complex decision-making. Instead of needing to memorize, hundreds of individual instrument names and their specific uses for every possible scenario, they can think in terms of these broad categories. This guides their choice based on the type of tissue they're dealing with and the action they intend to perform. So, for example, if they need to retract a piece of bowel, their mind immediately goes to the atraumatic category. If they need to grab onto a tough ligament, they'll consider the traumatic options.
Right, so you can almost imagine how the system probably evolved over time, maybe as laparoscopic techniques got more refined, more varied.
Absolutely. You can speculate that in the early days, perhaps the range of instruments was more limited, and surgeons had to adapt, maybe so optimally sometimes. But as experience built up and procedures became more complex, feedback from countless operations, both the successes and, importantly, the complications would have pushed instrument designers to create tools that fit these precise categories. This ensures both, optimal efficacy in achieving the surgical goal and, even more critically, patient safety. So yeah, these broad categories translated to very specific tools designed for very specific jobs, letting a surgeon perform their art with precision and confidence, knowing they have the right extended hand for the task.
That's a brilliant way to frame it. It really shows how surgical needs drive that innovation forward. Okay, so let's now really dive into how that specificity comes to life with the different instrument types themselves. Let's start with atraumatic graspers. The term atraumatic, as you hinted, might sound almost like an oxymoron in surgery, right? We're talking about instruments that pick up, hold, and manipulate, yet the absolute main goal is to do no harm to the tissue being handled. It's just vital. Our sources highlight specific, well-known examples, the Babcock and various bowel graspers. And these aren't just generic clamps, they're designed with an almost empathetic understanding of the tissues they'll interact with.
That's a good way to put it, empathetic design.
Yeah. So when we analyze what atraumatic actually means in their design, it implies several key things. Deliberate features. These instruments are engineered to distribute pressure over a larger surface area rather than concentrating it at one single potentially damaging point. They often have rounded, non-serrated edges or maybe a series of delicate, wide-spaced teeth that gently cradle the tissue instead of piercing, tearing, or crushing it. Think about the difference between holding a delicate piece of silk gently with your open palm, evenly spreading the pressure, versus pinching it tightly with sharp tweezers. Atraumatic graspers are designed for that gentle, expansive, palm-like hold, precisely because they're meant for the most delicate tissues. And this is so crucial for you, listening, to understand. Just imagine the delicacy of tissues like the intestine. Its walls are incredibly thin, fragile, and highly vascular. Any damage, a perforation, a crush injury that cuts off blood flow, even just disrupting the tissue layers could have severe, potentially life-threatening consequences for the patient. We're talking leakage of bowel contents, ischemic damage leading to tissue death, and the potential for severe infection like peritonitis or even sepsis.
Indeed. The necessity of these atraumatic tools, especially for structures like the bowel, it just cannot be overstated. The directive in surgical training and practice is exceptionally clear. Use atraumatic for bowel. And the why behind this, as you said, is rooted deeply in the nuanced physiology and histology of the GI tract. The bowel, especially the small intestine, has remarkably thin, friable walls, multiple delicate layers that are just easily compromised. It's also exceptionally vascular, meaning it has a rich, intricate blood supply that's highly susceptible to even moderate sustained pressure.
So even a little too much squeeze could be disastrous. Yeah.
Exactly. Any significant trauma from an instrument, whether it's a sharp edge, excessive force, or even just clamping it for too long, can lead to immediate perforation. Or, perhaps more insidiously, it can cause ischemic damage. That's where blood flow to a segment of the bowel gets interrupted. This can lead to localized tissue death, necrosis, which might not even show up for days. It could cause delayed perforation when the patient is already recovering at home. Both scenarios are incredibly dangerous. Leakage of bowel contents into the sterile abdominal cavity can trigger a cascade of severe infection, peritonitis, potentially life-threatening sepsis. And the evolution of these designs is a fascinating journey, often driven by a mix of clinical need and technological advancement. Early laparoscopic tools might have been less refined. Surgeons would have learned quickly, often through difficult experiences or post-op complications, the critical need for gentler instruments. This direct feedback from the OR floor would have pushed engineers and material scientists to develop specialized jaw geometries, specific curves, wider openings, more distributed gripping surfaces. They were seeking that perfect balance, enough grip to manipulate the tissue effectively and safely, but without compromising its structural or physiological integrity. It's a delicate, ongoing balance, a real testament to the collaborative effort between clinicians, material scientists, and instrument designers constantly seeking perfection. But, as you pointed out, not all tissues are so delicate. Which leads us to our next category, where a firmer, more assertive grip is not just allowed, but often critically required.
That's a crucial distinction. So pivoting from that gentle touch, we now move to the traumatic graspers. The name itself, traumatic, can sound quite aggressive, maybe even alarming to someone not in the field, especially when we're talking surgery. Our sources mention examples like the Alice grasper and various toothed forceps, but it's absolutely essential to understand that traumatic in this specific surgical context is controlled. It's deliberate and entirely purposeful. It refers to a design that allows for an extremely firm, secure grip on tougher, more robust tissues, often achieved with pronounced serrations, interlocking teeth, or even sharp points on the jaws of the instrument.
Right, it's about function, not aggression.
Exactly. Think about it this way. If atraumatic graspers are like using a soft, silicone-tipped utensil to gently lift a delicate pastry without leaving a mark, then traumatic graspers are like confidently using a sturdy pair of tongs to grip a solid, maybe slightly slippery piece of meat or a dense vegetable. The intent isn't to damage unnecessarily, but to get a grip that simply cannot slip, especially when you need considerable retraction force. Surgical judgment is absolutely paramount here. Knowing when to apply this more aggressive grip, and maybe more importantly, where in the anatomical field, is key. You would never, for instance, use these on a delicate blood vessel or inside the bowel. But for other specific tissues, as we'll hear, they are absolutely indispensable for safely and efficiently getting the job done.
Precisely. And these traumatic tools are indeed specifically designed for a very particular application. The directive is use traumatic for fibrous tissue. Now, what exactly constitutes fibrous tissue in surgery? Well, we're talking about dense, robust structures like fascia. That's the tough, sheet-like connective tissue enveloping muscles and organs, or strong ligaments that connect bones or even muscle itself, especially when you need a strong, unwavering retraction to expose deeper structures. These tissues are characterized by a high collagen content, which makes them dense, less elastic, and often less vascular than, say, delicate organs. Consequently, they can withstand significantly more pressure and a more aggressive grip without immediate catastrophic damage compared to, say, the thin wall of the bowel or the delicate capsule of the spleen.
Okay, that makes sense. And what about removing tissue?
Yes. Additionally, when a surgeon needs to remove a piece of resected tissue, maybe a diseased gallbladder, a portion of a tumor that's no longer vital, or a segment of omentum that's been removed, these instruments provide the secure, non-slip hold necessary to manipulate it and extract it safely from the abdominal cavity. The inherent challenge, of course, is always that balance, getting a strong, secure grip on the target tissue while meticulously avoiding any collateral damage to surrounding more delicate structures. A surgeon learns this precise control through years of intensive training, developing a highly nuanced feel for tissue consistency and instrument feedback, even when operating indirectly via a screen. This is really where the artistry meets the science in surgery. And this raises an important question for you to consider. Beyond just grasping and holding, Sometimes a surgeon needs to carefully separate tissues, meticulously define anatomical planes, work around vital structures. How do they achieve that level of precision when just gripping isn't enough?
Exactly. That leads us directly to dissectors, which are really fascinating because while they can indeed grasp and hold, their primary, more nuanced role suggests something much more intricate than just a simple clamp. We're talking about instruments like the Maryland dissector and the right angle dissector. While they are frequently, pressed into service for general grasping and retraction, it's their unique and very specific shapes that truly set them apart, optimizing them for precision work. The Maryland, for instance, typically has a distinct, often slightly curved tip with fine, usually atraumatic serrations. The right angle, in contrast, has that pronounced L shape at its working end, often with blunt, rounded tips. These designs are meticulously optimized not just for holding, but for carefully separating tissue planes, meticulously isolating vessels or ducts, or delicately passing ligatures, like little ties around structures deep within the body. They are, in essence, the surgeon's tools for creating space, defining boundaries, and elegantly revealing the underlying anatomy. Kind of like an archaeologist carefully brushing away soil to reveal an ancient artifact.
That's a great analogy.
Yeah, imagine using a specific, finely crafted tool to meticulously untangle a complex knot, carefully separating each strand to understand its path, versus just trying to pick up the whole intertwined rope. Dissectors allow surgeons to perform this kind of intricate, detailed, almost forensic work. This really highlights a fundamental aspect of surgery that often goes unappreciated, and it's not just about cutting or removing. It's about an almost artistic understanding and careful separation of anatomical layers, appreciating the intricate three-dimensional architecture of the body, and performing a precise, almost sculptural task to expose exactly what needs to be seen and acted upon all through these tiny ports.
And you've really hit on a critical point there. The conceptually nuanced application of these instruments. The Maryland and right angle dissectors are indeed critical for meticulously exposing structures and precisely preparing them for the next steps, like cutting, clipping, or suturing. The specific angles and curves of these instruments are anything but arbitrary. They are precisely engineered to allow surgeons to, well, work around corners, navigate in tight confined spaces, and gain visibility and access that straight graspers or conventional forceps simply couldn't provide.
So the shape is really key to function.
Absolutely. Consider the Maryland's curve, for example. It allows for precise blunt dissection along fascial planes, gently pushing tissues apart along their natural cleavage lines rather than tearing them. This curve also lets the surgeon see around corners on their monitor, giving a better view of the tip and the tissue being manipulated, and helps apply uniform, controlled pressure. The right angle dissector, with its sharper 90-degree bend and often blunt, robust tip, is invaluable for hooking around a duct or a vessel like the cystic duct or artery during a gallbladder removal to safely isolate it. This critical step ensures clear margins and prevents accidental damage to adjacent vital anatomy, like the common bile duct, before a clip or ligature is applied. Without these uniquely angled tools, many modern laparoscopic procedures would be significantly more challenging, if not downright impossible. And this connects directly to the paramount role of visual feedback in laparoscopic surgery. Because the surgeon is operating by watching this magnified high-def image on a screen, the instruments themselves are designed to maximize what they can see. The slender shafts and precisely angled or curved tips of dissectors are crafted to minimize obstruction of the visual field. This allows the surgeon to maintain a clear sightline of the delicate structures they are manipulating, the tissue planes they're developing, and any energy fields they might be applying. It's a profound example of how the tools and the advanced visual technology work hand in hand to effectively extend, and in some ways even augment the surgeon's capabilities, pushing the boundaries of what's surgically achievable through minimally invasive approaches.
Building on that ingenuity, that specialized thinking, we then move into the realm of specialized tools. This is where you truly see surgical innovation at its most responsive, directly addressing very specific, often unique surgical challenges that general instruments just can't handle. Our sources mention tools like the EndoClinch stone-holding forceps and specimen retrievers. These aren't your general-purpose instruments you'd find in every basic surgical tray. No, they are purpose-built, highly refined solutions to particular problems encountered in the OR.
Tailor-made, essentially.
Exactly. Let's break them down because each one tells a story of a specific problem solved. An endoclinch, for instance, is specifically designed to clinch or securely hold tissue with remarkable precision. What does it clinch? Well, it might be used for temporary occlusion of a small vessel to control a pesky bleeder during dissection, acting like a tiny removable clip. It's invaluable for securely holding a suture tail during intricate knot tying in tight spaces, giving the surgeon a firm grip. Or it could be used to gather and hold a portion of tissue for retraction, providing a stable anchor point. Its design typically focuses on strong, localized pressure with a secure, non-slip grip that can be quickly applied and, just as importantly, quickly released, often featuring a fine, delicate tip for pinpoint control.
Very specific uses.
Right. Then there are stone-holding forceps. Think about the inherent challenge of grasping a gallstone or a kidney stone. They're often hard, smooth, sometimes irregularly shaped, and incredibly slippery, especially when wet with bile or urine. Standard graspers might crush them into smaller, harder-to-retrieve fragments, or worse, let them slip away into the abdominal cavity, where they could cause further problems. Stone-holding forceps are a marvel of specialized engineering. They would have a unique jaw design, maybe featuring tiny flexible baskets or broader fenestrated cups with rounded edges, or specific non-traumatic serrations, things that can securely encompass and hold a hard object without crushing it, preventing it from escaping. They are designed for control, not crushing, ensuring the integrity of the stone for removal and analysis.
Essential for certain procedures, then.
Absolutely. And finally, specimen retrievers. This is just a brilliant solution to a very practical problem. How do you safely remove a resected organ like a diseased gallbladder or a piece of a tumor or even a foreign body through a tiny incision, sometimes just a few centimeters long, without contaminating the surgical field with potentially cancerous cells or having to make a larger, more invasive incision just for removal? Specimen retrievers are typically sterile bags or nets, often made of very strong tear-resistant polymer mesh. They can be compactly deployed inside the body through a small port. The resected tissue is carefully placed inside, and then the bag is securely closed with a drawstring or some kind of self-closing mechanism. The sealed bag, with its contents, is then extracted through the small port. This ingenious method prevents spillage, minimizes the risk of infection or seeding cancer cells, and ensures that the cosmetic benefits of minimally invasive surgery are maintained. These instruments are like the highly specific, purpose-built tools in a master carpenter's or mechanic's kit designed for one particular job, but absolutely indispensable when that job needs doing. They truly showcase how surgical innovation is constantly responding to practical, real-world challenges encountered in the operating room, making previously difficult or even impossible tasks routine, safer, and more efficient.
Absolutely. And when we connect this to the bigger picture, these specialized tools truly represent the ongoing dynamic collaboration that defines modern medicine. It's that synergistic interplay between surgeons identifying unmet needs, engineers conceptualizing solutions, and material scientists providing the advanced compounds and alloys to bring those solutions to life. They're constantly pushing the boundaries of what is possible in minimally invasive techniques. Each of these tools directly addresses a specific, previously challenging problem in complex procedures. This allows for safer, more efficient, and often more extensive laparoscopic operations. For example, the development of robust, sterile specimen retrieval bags directly contributed to the expansion of laparoscopic surgery for cancer cases, where preventing the spread of cancer cells within the abdomen is absolutely paramount. Without such innovation, many patients would still face larger open surgeries with longer recovery times for similar conditions.
It really changes the game for patients.
It absolutely does. And we could even speculate about the fascinating future of surgical tools. We're already seeing breathtaking advancements in new materials. Think of flexible robotics that can articulate in ways a human wrist just cannot, or biocompatible alloys offering incredible strength in incredibly tiny forms, or even smart polymers that change properties in response to temperature or pH. These innovations will undoubtedly lead to even more specialized, adaptive, and perhaps even intelligent instruments. Instruments that can provide real-time haptic feedback, maybe automatically adjust gripping pressure based on tissue properties, or even incorporate microsensors for real-time diagnostic info. Imagine instruments that not only extend the surgeon's hands, but also augment their senses and cognitive capabilities, further enhancing precision, reducing human error, and pushing the frontiers of patient care to levels we can only just begin to imagine today. It's a field of continuous, breathtaking innovation, always driven by that core purpose of improving patient outcomes.
That's a powerful and exhilarating thought, the idea of intelligent instruments working with a surgeon. But as we've discussed repeatedly, the most cutting-edge tools in the world are ultimately only as good as the hands that wield them, and crucially, the knowledge of how to wield them safely and effectively. This transitions us perfectly to the non-negotiable rules of engagement, the absolute principles governing safety and efficacy in practice. Our source material includes a specific safety tone for this section, indicating its paramount importance. In high-level medical conference, this would be the session where the most critical life-saving directives are emphasized and dissected. This is truly where the rubber meets the road. The practical, foundational knowledge that saves lives, prevents complications, and defines competent surgical practice. These aren't just suggestions, they are directives etched into the very fabric of OR protocols.
Indeed, these are the commandments of safe laparoscopic practice, the absolute bedrock upon which successful outcomes are built. Let's break down each safety directive from the source, meticulously exploring the detailed why behind each rule, because understanding the why fosters adherence and critical judgment. First, and perhaps most foundational, use atraumatic for bowel, traumatic for fibrous tissue. We've touched on this, but it's worth hammering home and expanding on the stark, often catastrophic consequences of misusing these instruments. Imagine just for a moment this scenario. A surgeon inadvertently reaches for a toothed traumatic grasper and applies it to the delicate wall of the small intestine. The sharp teeth, designed for tough fascia, could easily pierce or tear the bowel, leading to immediate perforation. This, as we mentioned, can swiftly result in leakage of intestinal contents, triggering severe abdominal infection, peritonitis, potentially rapidly progressing to sepsis. That's a life-threatening, complex chain of events requiring emergent intervention.
A terrible outcome from a simple mistake.
Precisely. Conversely, trying to use a gentle atraumatic grasper on tough, fibrous tissue like dense, calcified fascia, or the thick ligament during a demanding retraction might result in an insecure grip. The instrument could slip, causing unintended injury to adjacent vital structures like nerves or vessels, or it could lead to an incomplete dissection, which prolongs operative time, increases blood loss, and elevates the overall risk of complications. It's not just about what the tool can do, but what it should do. Precisely matching the tool to the specific task and tissue. Think of it like trying to unscrew a Phillips head screw with a flathead screwdriver. It just won't work right. You'll likely damage the screw, maybe your workpiece, and you certainly won't get the desired outcome. Each instrument has its precise indication, and sticking to this rule is fundamental to preventing preventable harm and ensuring surgical efficiency.
Okay, that's crystal clear. What's next?
Secondly, and this embodies profound surgical skill, avoid excessive force. This is a deceptively simple statement that truly encapsulates one of the most crucial and subtle skills for a surgeon. Understanding tissue resistance and applying just the right, judicious amount of pressure. In laparoscopic surgery, without that direct tactile feedback from their fingertips, surgeons rely heavily on a synthesis of visual cues on the monitor, subtle haptic resistance transmitted through the instrument's shaft and handle, and their ingrained motor memory. Excessive force, even when using the technically correct instrument for the tissue type, can cause a whole list of issues. You can cause tearing of tissues, creating ragged edges that are harder to repair, bleed more, and heal less cleanly. You can induce crushing injuries, which damage the microvasculature and cellular structure, leading to localized tissue death or necrosis that might not become clinically apparent until days after the surgery.
So damage that isn't immediately obvious.
Exactly. Furthermore, excessive pressure can inadvertently damage delicate nerves, leading to postoperative pain, numbness, or even a loss of function in the affected area. It can also compromise blood vessels, causing bleeding or ischemia to downstream tissues. The goal is always delicate, controlled action, almost like a dance with the tissue. How do surgeons develop this incredibly nuanced feel without direct contact? It's through extensive, rigorous training. Countless hours in simulation labs, maybe with haptic feedback technologies trying to mimic the sensation of touch, detailed cadaveric dissection, and years of apprenticeship alongside experienced mentors. They learn to interpret subtle visual changes the way tissue blanches or stretches, and combine that with the nuanced resistance feedback from the instrument itself. They internalize the appropriate amount of force for various tissues and tasks. This development of surgical touch in a mediated environment is really a cornerstone of modern surgical education.
Fascinating. And the final safety point.
And finally, a truly critical, often unseen check insulation. This seemingly small detail really underscores the high stakes and the meticulous detailed protocols in the operating room. What exactly is this insulation? Well, on a laparoscopic instrument, it's a protective coating, typically made of durable, non-conductive materials like plastic or silicone. It covers the metal shaft of the instrument, leaving only the working tip exposed. Why is it there? The vast majority of laparoscopic instruments are designed to be used with electrosurgery, often just called cautery. This involves passing an electrical current through the instrument's tip to precisely cut tissue or coagulate blood vessels to control bleeding. Now, if the insulation on the shaft is damaged, even a tiny hairline crack, a pinhole, or a subtle abrasion that's almost invisible to the naked eye, it creates a pathway for that electrical current.
Oh, I see where this is going.
Right. The danger is that this current can then arc or jump to non-target tissues. Imagine the instrument shaft with compromised insulation inadvertently touching a loop of bowel or a ureter or a major blood vessel that is outside the surgeon's direct field of view on the screen. The electrical current can jump from the damaged insulation to these adjacent healthy tissues, causing an unseen burn. These silent burns are incredibly insidious because they might not be immediately apparent. They can lead to delayed complications like bowel perforations manifesting days later as severe peritonitis, or strictures of the ureter requiring further surgery down the line. It's like using a frayed electrical cord in a highly sensitive environment. The danger isn't always immediately visible, but the potential for catastrophic consequences is immense.
That's terrifying.
It underscores the importance of checks. Meticulous preoperative checks of every single instrument by both the surgical technicians and the surgical team are just as critical as the surgery itself. In fact, technology is continuously advancing. Some modern electrosurgical systems even incorporate automatic detection of insulation breaches through impedance monitoring, adding yet another crucial layer of safety. This meticulous attention to detail at every single step, from preparation right through to execution, is what truly defines safe and responsible surgical practice.
Wow, that really brings home the level of care required.
So if we connect this all back to the bigger picture, what we've explored today is, well, it's far more than just a list of tools. It's really an appreciation that understanding these instruments isn't merely about memorizing names or functions. It's about deeply appreciating the meticulous design, the profound surgical decision-making, and the rigorous patient safety considerations that are inherent in every single step of minimally invasive surgery. These instruments, truly the sophisticated hands of laparoscopy, give surgeons incredible control inside the body, allowing them to operate through tiny incisions. And this technological and procedural advancement directly translates into tangible benefits for you, the patient. Smaller scars, significantly faster recovery times, less postoperative pain, reduced risk of infection, and ultimately vastly improved overall health outcomes. It's really a testament to human ingenuity relentlessly applied in the service of health and well-being, constantly pushing the boundaries of what is possible.
What an incredible journey into the precision and the critical safety measures surrounding these surgical tools. So what does this all mean for you as someone now maybe more informed about the hidden complexities of modern surgery? We've explored in depth how surgeons grasp and hold with incredible precision through these tiny portals, but that's only part of the story, isn't it? The next logical step in pretty much any surgical procedure involves cutting and dissecting, actually incising, dividing, or separating tissues. So how might the challenging and the innovations required for those instruments be profoundly different from the grasping and hoarding tools we've discussed today? Consider the added risks of inadvertently damaging vital structures nearby, the absolute need for perfect hemostasis blood control right at the cutting edge, and the even greater demand for precision when making an incision or separating tissues within that confined indirect visual field of laparoscopy. How do surgeons achieve that level of controlled destruction safely? That's maybe a thought to mull over. Pondering the continuous evolution required to keep pushing the boundaries of what's possible in the operating room. Until our next deep dive.